Today, we're going to talk about whether we should premedicate patients when they come to the vet. And these are two of my dogs. This is Hamilton on the left and Annie on the right, and they go kayaking with me. They swim alongside while I kayak, and this is the beach where we live. You can see how clean the water is. They're just, I'd say the quality of their life and their welfare is pretty good. So let's talk about what happens during veterinary visits. And let me define welfare in the context of a veterinary visit, because it's a slightly different definition than we often use. So much of the definitions that you'll see on about welfare have to do with production animals or forcing animals into situations which are not naturally theirs. And when you've got species like dogs and cats, dogs have lived with humans for at least 35 to 40,000 years, intimately, and certainly within the context in which we're living with them, 15 to 20,000 years minimally. It may be as high as 35,000. Cats, minimally 12,000, 15,000. So, you know, we're not talking about taking a tortoise out of Africa or a cow and putting it in a feedlot. So when we talk about welfare during veterinary visits, I want you to think of welfare as the well-being of companion animals in terms of their emotional, cognitive, and physical health. So well-being here is a three-part definition: emotional, cognitive, and physical aspects. You have to evaluate this situationally, so not just veterinary visits as opposed to going to the beach, but that veterinary visit in that veterinary hospital. And these three components of well-being and welfare intermingle and co-vary mechanistically. In other words, if you have a problem emotionally, it will affect your cognitive abilities, and both of those together will affect your physical abilities. If you're physically ill, you're likely to have both emotional and cognitive effects, and depending on your temperament and whether or not you have behavioral problems, you might have a far more profound emotional effect to being ill and have bigger cognitive. Nobody's measured these, and it's a problem, but it's also a wide open field of research. The effects can be time delayed and time penetrant. And this fits with studies that have shown that the more often you go to vets, if you're ill, the more pronounced some of your anxieties might be. Whereas puppies who have good experiences and go frequently can view vet visits as a great thing. So it very much depends, again, on the situation and the timing. And it requires an objective consideration of the effects of our actions on an individual basis. Not our intent. Very few veterinarians set out to cause a behavioral pathology of fear with which their patients are going to be afflicted for their life, and which will make every veterinary visit in the future difficult. I don't think anyone's setting out to do that. Our intentions don't matter here. What matters is what effect our actions have, and is there sufficient variation in those effects dependent on the variation in our actions, that perhaps there's a better way to do this. And I'm going to tell you the answer is yes. And I guess my question to people would be, why would you not premedicate your patients if it helps prevent anxiety and fear? Fear and anxiety, again, are time penetrant. If you practice them, if you experience them frequently enough, they will get worse. People talk about stacking of triggers. It's a pop psychology phrase. But, you know, a lot of things happen in our lives. If you live in a city, there may be traffic, there may be weird things going on with horns and backfires and just general noise and congestion and an inability to run free. And so you may have exposure to many more triggers of fear and anxiety than a suburban or a rural dog does. On the other hand, some of the environments that other types of dogs face, having to do with weather and wind and predators and farm equipment. Everybody's got their stressors. We don't need to add to anyone's stressor by being unintentional in our actions. So let's talk about how we make decisions. Who needs to be premedicated, who doesn't? Do we just give everybody drugs? Well, in truth, you could, and you probably wouldn't be doing a lot of harm. You might not do any harm. It might minimize the cost of error, but there is a more rational way to do this. Not every individual, excuse me, who comes into your practice is going to be afraid of you. So I've developed this go, no-go algorithm, and I developed this a number of years ago for clinical situations. And this is the general one, and I'm going to walk you through this. And I'm actually going to have the chap who does the website, which is just karenoverall.com, put these on the website so that they'll be available to everybody. So look at the situation, and in here it's any situation. And this is the general way to think. And I think that the best way you can be prepared, believe it or not, is to have a series of if-then flow charts. I think of my entire life as sort of dichotomous choices. It doesn't mean there are only two choices. It means I have branch points for everything. And if that didn't work, what's my backup? And if that didn't work, what's my backup? So here's this, any veterinary situation. Can the dog do it happily? If they can, start the scenario. Are they still happy? How do you know if they like the treats you have or toys, or they enjoy love and attention and they can take those? Then they're doing pretty well. Go and progress kindly and mindfully. That doesn't give you the opportunity to rough up the dog just because he's gentle. In fact, we had sort of a heartbreaking moment in my resident Camille Squares study recently, where at the end we disclosed to people whether they were in the interventional group or the control group for veterinary visit manipulations. This is part of her master's work. And one of the people who had an absolutely fantastic Labrador Retriever was almost crying when she found out he was in the control group. And she asked if he'd been put in the control group simply because he was a nice dog. And, you know, they were blinded and assigned completely randomly by computer. And we explained this to her, but the fact that people have the impression that we treat dogs based on how they behave and may not give some of the benefits to really nice dogs is a concern for me, partly because I think it may be accurate. So if this dog starts out distressed, ask yourself, can I change the environment? Can I change the perception of it? Can I give the dog a thunder shirt? Can I put on a white noise machine? Can I move it to another room? Can I move it to a room with a window where it can be distracted? If the dog is calmer, you can go. What if that dog is still distressed? Or what if that dog starts out okay? This is the dog in the first scenario, and suddenly is unhappy and can't take treats and shaking. Well, both of these dogs now fall into the still distressed loop. Talk to the clients and get some history. And this is a great time to whip out a one-page questionnaire to find out, is there any history of fear and anxiety? It's going to take the clients roughly a minute or two to complete that. It can be done on an iPad. A technician can do it. You can ask. They can use a piece of paper. But it should be part of their permanent record. If you get a history and realize, ooh, there is a history here, do I think I can mitigate the distress? And for that, you could use short-term fast-acting meds, and they're willing to let you do that. You give the meds, they're happy, or go. If they are still distressed, you're done. Now you need a plan for the future. If you get a history and you think, geez, no matter what I do, this animal is potentially going to get worse, or there's a risk here, I could trigger something that they've done a tough job of avoiding or controlling, stop. Defer seeing this patient, develop a treatment plan, not just for the problems that are going to contribute to the worsening, but for how you're going to handle this patient the next time they come in. Okay, now I'm going to go through this in a specific scenario. They walk through the door, they go to the scale, they get into the exam room, and it's a complex schematic, but I'll walk you through the pieces. But in that, I talk about a couple of medications. So we're going to talk first about these meds, and then we're going to come back at the end of this and talk more specifically about medication use. So your medication choices are really in these scenarios that I just outlined. Alprazolam, a fast-acting benzodiazepine, and this is the benzo that's considered the panicolytic medication. It'll take effect in about 10 to 20 minutes. Gabapentin usually takes effect in 30 to 60 minutes. It's a gabapentinoid. Pregabalin, again, 30 to 60 minutes. It's a gabapentinoid. And oral transmucosal dexmedetomidine gel or solution. Now, the gel is commercially available as Cilio. It's an alpha-2 agonist. It takes effect in about 20 minutes. You can almost set your clock by it. You can make a solution if you don't have the gel, but you will not have as exact results. Clonidine, and that's an alpha-2 agonist. Clonidine is an alpha-2 agonist for the purposes of this argument, but it also has alpha-1 and beta-1 and 2 receptor effects, and it can act as an antagonist in some parts of the brain, and we're going to talk about that later. And then Trazadone, which I'm sure everybody who's a veterinarian is familiar with. It's a serotonin antagonist reuptake inhibitor, or SARI. It's also being variously classified as some other things, but this is the most common classification. The medications that have asterisks actually have published data, and I'm going to show you the published data for everything except the pregabalin, which may be a wonderful medication for cats, because actually that paper wasn't out until just recently, and the data I'm going to show you are from a paper that just appeared this week. So hold in your heads the idea that pregabalin is a great medication for situational anxieties in cats. Benzodiazepines stimulate inhibitory neurotransmitter, the inhibitory neurotransmitter GABA, gamma-aminobutyric acid, by binding to the GABA-A receptor to counterbalance the excitatory neurotransmitter, the excitatory amino acid glutamate. So benzos help to inhibit or modulate a response. Both of the gabapentinoids, both pregabalin and gabapentin, and they work slightly differently. They have slightly different kinetics, but they depress neuronal excitability, triggers through binding to the alpha-2 delta-1 subunit of the calcium channel in inhibitory neurons to stimulate descending inhibition. They seem to help sequester glutamate into astrocytes. And they may have secondary effects on GABA receptors so that there's maybe a further inhibitory effect, but those are going to be indirect. They were designed to be GABA mimics, benzo mimics that affected GABA, and that's not what they do. They affect calcium channels. And they inhibit or modulate a response. Alpha-2 agonists, Cilio, abort or prevent the initial burst of norepinephrine from the locus coeruleus as part of the arousal trigger for the sympathetic response. So you get into the vet's office, you realize you're there, you're suddenly aware of it, you've got a sympathetic flight or fight arousal response, except you don't, because you're already pre-medicated with Cilio, and you get into the vet's office and you realize where you are and nothing happens. And that's what we want. You don't have that response. Clonidine is, as I said, in some cases, an alpha agonist. It's a partial alpha agonist, but again, it depends very much on the region of the brain. It's a partial alpha antagonist. It acts in the posterior hypothalamus and medulla as an alpha antagonist to decrease sympathetic blood flow and to lower blood pressure, but in the anterior hypothalamus, it actually excites a pathway as an alpha agonist to inhibit cardiac neurons. So you get an inhibitory or modulatory response because those neurons now don't fire and you don't get the sympathetic response. The only one of these medications that has a veterinary license currently is Sileo, the dexmedetomidine oral transmucosal gel. And I need to declare something right now before we go any further. I act as a consultant for many, 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 many drug companies. I actually acted as a consultant for the development of Sileo and helped design the experiments that got it licensed. So my hands aren't clean in the sense that I had some insider knowledge, but I'm going to tell you that nothing works for everything. And there are certain situations in which Sileo may be great and certain situations in which you might do just as well or better with some other medications. Okay, so let's look at this more complex sample go, no go algorithm. So let's talk about entry into the clinic. Okay, so here we've got the dog goes through the door happily. Great. Put down a mat in the waiting room or the exam room. It depends on the clinic's policies, whether they have them wait in a waiting room or an exam room. With COVID, one of the wonderful things is that they've been able to hang out in the car and not get excited by waiting rooms. And then if they do come in, they go directly to an exam room, which may be preferable for many dogs. If they do well in the waiting or exam room, they take treats. Fabulous. Go ahead, just be mindful and kind. If they're in the waiting room or the exam room and they suddenly realize where they are and they're unhappy and they don't take treats and they're shaking, change to a bigger room. Windows, I'm a big believer in windows, bird feeders, dog water dishes outside, things they can see. It makes a huge difference to dogs. Stick a licky mat right on the window and see if they'll take food. If they're still distressed, talk to the clients and get a risk history. Can we mitigate it there and then? Sure, you can try it with fast-acting benzos. I would prefer that to Trazadone for a number of reasons we'll discuss later. And rewards. Is the dog still unhappy? You're done unless this dog's practically bleeding to death. If the dog is happy, great. What if you find out there's a concern of worsening? Oh, you stop because you're not prepared for that. You're not prepared for the downstream effects. You don't know if there are risk factors that haven't been addressed. You have to wait. What if they walk in and they're already upset and they're panting and they're scanning and they're salivating? If they can walk without resistance, if you can jolly them along and put them in a quiet room for 20 minutes, some studies have shown that they will calm down enough that they will return to baseline. If they can take treats, you can go. If they can't take treats, consider how the anxiety and the exam will be affected by this. You don't want aberrant lab work in some animals, so this won't work because remember, stressors affect lab work and you don't want the clients paying for a lab work you can't interpret. So decide what you're going to do. Is this a new response? Have the clients never seen it before? Is it a worsening problem? Is it in your record? Or is it a long-standing problem? A new response, give them a benzo, wait 20 minutes and see what happens. You could use Sileo, wait 20 minutes, see what happens. If it's a problem that's been worsening, try treating it now. I would reach for Sileo and a benzo before I would reach for clonidine, where you're going to need an hour, and Trazadone, where you're going to need about an hour. But if they're coming back later in the day, those are options. If they're better, go with caution, but they need help in the future and you need a plan before they leave. If they're still distressed, you're done. Stop. If this has been a long-standing problem, treat now with Sileo or alprazolam and plan to go forward only if the risk of worsening anything else is very low and the dog is extremely compliant. If you can't do that, you're done. They go home. And basically, you're right back up here with the dog who can't get in the door. And now you have to figure out how to relieve this for the future. You have to figure out if there are other problems. And you are not going to force the dog in because compulsion is not a solution to this. You will make all these fears and anxieties worse. So if they're already that distressed, my version of dealing with this is I might give them alprazolam to scramble the short-term memory and send them home. I want them to have a good time. We can plan, we can just see the client and talk about the issues. They can come in a few days or a week later. We can plan for this. We can send home pre-medication for the dogs. They can have maybe a couple of days before, a day before, a few hours before, 20 minutes before. We may combine all of those, but you have to standardize your decisions because you have to be able to make these in a rational way. And there are a couple of ways you can do this so that you get good at assessing who's going to succeed and who's going to fail. You may have seen a number of these. Sometime in the early 2000s, I started the first round of these stress level scales, and they've since evolved considerably. This is the most recent one, and this one evolved even further with these detailed, highlighted benchmarks from Dr. Camille Square's master's study, because we had a whole bunch of undergraduates and vet students volunteering in the behavior clinic to help us work with these dogs in a set of an interventional study, which was behavioral interventional, with some medication as rescue medication, and control dogs just having regular standard veterinary exams. And we saw these people every 2 weeks for 4 visits for a few months, and we had all these students, and we watched videos and we watched dogs and we validated these. And every time the student said, I think another word could help, I think a little tweak here, and I can separate 1 and 2 or 3 and 4. Everybody has trouble with 3 and 4. Sometimes people have trouble, believe it or not, with 0 and 1. And I always call 0 the dog who is so thrilled to be there that you don't really understand it, the very happy Labrador. But you can have some very calm and relaxed, seemingly unmoved dogs who are happy. And the key is the unmoved dog is like, yep, I'm happy, but I'm not happy any differently here than I am elsewhere, whereas this guy bounces off walls. And the only reason we mark the bouncing off walls one is those guys can have their own particular set of problems. People generally have trouble with 2 and 3 or 3 and 4, high levels of 2, low levels of 3, and where do we go from a high level of 3 and a low level of 4. So we added these benchmarks. So we assess dogs when they come into the clinic. We assess them when we're weighing them. Basically the same scale with some changes. So can they calmly get onto the scale but not sit on it? You know, the first dog, a 1 here, would walk onto the scale and sit when you asked. Number 2 is calm and cooperative, can get onto the scale but can't sit on it. 3 would be panting slowly. We could get them onto the scale, but only with encouragement. Their tail is down. And then you're into the dogs who are extremely tense. And any dog in this scheme who is a 4 or a 5, I almost don't want you to go any further without pre-medicating the dog. A 4 here is a very anxious dog who's shaking, who's hunched, who won't sit down or lie down if they're exposed, and they're going to be exposed on a scale. If they could hide behind their owner, they might sit down. They're panting, they're difficult to maneuver on a lead. They have to be helped or encouraged to get on or stay on the scale for 10 seconds. If they can't do that, they're a 4. And by the time you get to the 5, they're gone. Okay, you have to force them onto the scale. We force nothing. Entering the exam room, same type of pattern. A 5, you're manually shoving this dog through the door to the exam room. That's not something we want. In a 4, they may be difficult to maneuver. They'll avoid the room. They'll have a hunched or lower body posture, but you don't have to physically pick them up and put them in the room or shove them in the room. So you'll get used to using these types of scales. And we also, as we put our hands on the dog to do the exam, we rate them. So we rate them the second we touch them to start the exam. And when we're done and we take our hands off and we do an exam in a standardized order, we rate them again. And that gives you an idea of, did you make the dog better or worse? You know, a dog who is a 2 or a 3, tense, but you're doing the exam slowly, you're talking to the dog, you may be offering treats, you're petting them, you can get them to a 2 or a 1 by the end. And if you can do that, it's important to know. But all of this stuff has to be part of the permanent record. You're not only discussing the dog's mental health and making a note of this, which is what this does, but you are using this to educate you about this dog's pattern and about other dogs in the future. So when you use these types of standardized veterinary visit assessments, you can incorporate them into these flow charts. So let's say the dog clinic stress entry scale gets a 0 to 3. Well, you can either start or you can place them in a quiet room for the 2s and the 3s and have them fill out the short AHA guidelines questionnaire. In 2015, I chaired a group of very dedicated people, including a number of veterinary behaviorists who were board certified, and created behavior guidelines. And one of the things that we recommended doing was assessing every single dog and cat, every single visit, using a 1-page short questionnaire that your receptionist does, that they complete online before they come to the clinic, that they complete on an iPad in the clinic, that they complete on a clipboard if you want in the clinic, but it becomes part of their permanent record. And it's a simple yes/no questionnaire that you're going to see in a minute. If you've got a dog with a score of 3, you're going to reassess them. Did they drop down to a 0 or 2, or did they go to 3 or increase to 4? You're not going to see a 5 on the scale. Why? Because I'm going to tell you to quit at 4. Okay. So you've had them complete the questionnaire. Now you're waiting to see how they are 20 minutes later. If they're a 0 to 2, you're going to go ahead and start. Okay. Now, if they had some flags in their initial questionnaire, we have an expanded questionnaire. It's not a full behavioral questionnaire, but there's an expanded questionnaire, and these are available on the AHA site. And you're going to use that to see, are there problems that we need to pursue? If that's positive, they fill out a complete behavior questionnaire and you set up a targeted behavior visit for them, or you send them to a specialist. So we're going to take them to the appointment, and most people weigh the dogs along the way. I'm going to tell you to change this. Weigh them at the end. Weigh them when they don't have to get on a wobbly surface and they know they're done and they're happy and they've had their treat. But if the dog gets a 0 to 3, you can take them into the exam room and see how they do as they cross the threshold. If the dog gets a 4, remember in the beginning we asked if they wanted to reschedule. Now we're just weighing the dog and he gets a 4. Tell them you need to talk to them about the distress and solutions that'll help prevent it. Okay. Review the questionnaires with them. Decide if you need a short visit. If the dog has a 4, you're going to have to say to them, look, I'm not sure we should go forward with the physical exam without using Sileo, alprazolam, maybe another benzodiazepine, which is slightly shorter acting and not as panicolytic as alprazolam, gabapentin. What I don't want you to do is give them Trazadone. Trazadone is sedative and won't work quickly enough to even mildly sedate an already aroused dog. And when you use Trazadone, you need to want sedation. You don't want anxiolysis. You don't want an anti-anxiety effect. And we'll talk about why in a minute. But usually what people are not evaluating is the extent to which the dog is less anxious versus slightly sedated. While the client is deciding with their dog who's a 4, if they should go forward with meds, have everybody sit down, get a drink, turn the lights down. Yeah, you might want to review the questionnaire again. And use the shorter survey questionnaire if you haven't already done so, the one that's going to expand on that 1 page. It'll take maybe 4 minutes of a technician's time. Flag the questionnaires in your records. Think about where you're going to go in the future. Are there lots of positive responses for the future? Well, if there aren't, you've got great management advice. The dog did well. You should be in pretty good shape. You can examine the dog. If there were a lot of positive responses on that 1-page questionnaire, they need more. Simple management advice is not going to get it. You're going to have them complete the targeted screens if you haven't already done so. And you're going to talk about the future. because this dog is not going to do this in a 20-minute physical exam. If you've given these dogs that are a 4 the medication and you've waited 20 minutes, ask if you can humanely do this without distress. If yes, go ahead and use your exam scales for the beginning and the end. And if they get back to a 4, stop. A 3, squint and ask if you should stop. If doing this didn't make any difference because they were already so far over the top that the medications are being overrun, tell the clients 2 things. A, we're going to reschedule, and B, in 3 or 4 hours, they're going to see the effects of these drugs probably. So reschedule them with a pre-visit medication plan that you're going to develop based on those questionnaires, both the short one and the expanded one, but not the full behavior questionnaire yet. Okay, and talk about maybe working with a trainer, a positive trainer who can help them learn to go to the vet, and talk about a management strategy for getting the dog and keeping the dog in a calmer state. Why are we going to go to all this effort? Because Brutocane doesn't really do any of us any good. Dogs and cats learn that they don't want to go to the vets. The clients don't want to bring them to the vets. The studies that were done in 2011, the bear study, showed that 60% of cat people don't take their cats to the vets because it's just so awful for them and the cat. And a decreased number of people take their dogs to the vet when the dogs are this problematic. We want them to come, and these dogs are the ones, and cats are the ones who are not getting the veterinary care they need. So we want them to come and have a great experience. And the only way we can do this is with a team approach. Think of it this way. Not only are you using your time more efficiently, you're not struggling, your anxiety is not going up, and you're safe. We are a lot safer when we do this than when we struggle. This approach mitigates the chances of being injured by your patient and the chances that you will injure your patient, albeit unintentionally. But trust me, a mental injury is going to be far worse than nicking their leg. Here are the AHA management guidelines. They were published in JAHA. They're available on the AHA website. And this is just the one-page questionnaire. And honestly, you can't ask for anything more simple to go into the record. We ask the dog's name, breed, the date, the client's name. We ask if they think the dog's house trained. There's a similar one for cats. Birth date. We want to know if it's an estimated or known birth date, because estimated ones could be really wrong, and that might factor into how we think about this. Their reproductive status, how old were they when adopted? Ooh, why? Because that's a flag for so many problems. Do you have any worries, complaints about urination in the house? Yes or no? Defecation, diarrhea, destroying anything, mouthing anyone, sounds that worry you, bark, snarl, or bite. Does your dog pull on the lead, etc., etc.? Yes or no? I'm not asking what you think. I'm not asking how you feel. I don't want your opinion. I just want to know if any of these things have happened. Has anybody told you they're worried about the dog? They may be wrong. Maybe they hate your breed. Maybe they don't know what they're talking about. But that may be out there in the community, and it's no longer a trivial risk. So this starts you off. It's a 60-second questionnaire that should be done at every single visit. Why? Because dogs change dramatically in the first couple of years of their life, and they change when they're older. So what this allows you to do, if you see the dog as a puppy every 3 to 4 months, as we recommend for the first 2 years of life, or you see them every 6 to 12 months while they're adults, and then every 6 months when they're aged, you have a very nice way of tracking this for you. So let's talk about how we're going to use these meds. It's not just about Trazadone, and I would really like people to stop just reaching for Trazadone for a number of reasons. First of all, the effects of Trazadone are nonspecific. It affects the 5-HT2A, 5-HT2C, alpha-2 adrenoreceptors, and a number of other monoamine receptors. But it has minimal anticholinergic effects. So one of the concerns that affects humans, that dry mouth, is not an adverse event for Trazadone. It has been linked to orthostatic hypotension in humans. Dogs walk on 4 feet. Probably they don't experience it that much, but there have been numerous reports. And in discussion groups, I think it might be fairly common at high dosages where these dogs get a little weebly wobbly. It's a powerful sedative. And the main use of Trazadone in human psychiatry is as an hypnotic. In other words, you use this hypnotic largely for disordered sleep associated with post-traumatic stress disorder. So this is not a primary anti-anxiety agent. The effects on the 5-HT2A receptors likely help with movement, which allows you to sleep. The anti-anxiety effects, and this has been known for 25 years, the anti-anxiety effects are due to the 5-HT2C receptor. And in order to get those effects in human medicine, you need 10 times, 100 times at very low dosages, but at least 10 to 50 times the amount of the medication you do to get the movement and hypnotic effects. We can't give that kind of medication dosage in our patients. We'll make them quite ill. We've already had one published case of serotonin syndrome with Trazadone at a dosage that's being published. People use anywhere between 1.7 milligrams per kilo to 7.25 milligrams per kilo per day on average, summed from clinical studies. There's a record out there of 17 milligrams a day. But I don't think most people realize there is no established dosage range in dogs or cats for Trazadone. No one's ever established it. And in the one placebo-controlled double-blind that was done, there was no effect on anxiety shown. So one of my concerns with Trazadone is most studies haven't separated out anxiety and sedation. And low levels of sedation can look like anxiety, except that they may have some impairments in activity and how they make decisions. If you were to take Trazadone to a regulatory agency to license it for dogs and cats, you would be required to separate those. So you would need criteria that allowed you to evaluate the difference, like all the drugs that have a veterinary license. So what I tell people about Trazadone, and I do recommend it sometimes, don't use it unless you're happy to have some sedative effect. So it can be great for some dogs who really need to sleep through their vet visit a little bit, or they don't mind them going home after their vet visit quiet, or they're recovering from surgery and we need to keep them still, quiet. You know, that can help. And it can be added to other medications, but don't make it more than it is. So the reported dosage range for Trazadone, just to give you an idea of how variable it is, this study had 6 cats in it, 10.6 to 33.3 milligrams per kilo. This study had 10 cats in it, 7.7 to 15.2. This study had 36 dogs in it, 3.5 to 7. This study had 59 dogs on Trazadone and 58 dogs in match group, 4 mg per kg. And this study had 14 Trazadone dogs and 15 placebo dogs, and it was 5 to 7 milligrams per kilo every 12 hours as designed. But the final actual dosage given was 2.8 to 10.8 milligrams per kilo every 12 hours. So we don't have a dose establishment study for this medication. What medications could we be using? Well, I've already told you. And what do we know about their dosages and efficacy? Interestingly enough, this paper just came out in the Canadian Veterinary Journal this week, finally. So you can actually go to the journal and see the actual article. This table is directly from the manuscript for the article, but this is a paper that we wrote during the pandemic with senior vet students who took a special topics course, and they did all the work, and I was the coach, and I helped them with the research and the writing and their thought process. And we found that the dexmedetomidine gel, sold as Cilio, and licensed for fear of noises in dogs. This is the dosage range, and it's on a per dot basis, which is calibrated based on this range. And you give it 1 hour before an expected noise. It's repeatable every 2 hours, up to 5 doses a day. And what is a noise? A noise is a situational trigger for anxiety. So here we have anticipatory anxiety, and we have non-specific anxiety associated with arousal. What else does that describe? Maybe getting in the car and going on a trip, maybe going to the vets, maybe leaving the house in the morning to go to work, maybe company coming to visit, maybe taking the dog to a training class or taking the dog elsewhere. There are loads of various situations where situational anxiety and arousal matter that Cilio could help with. And it won't help every dog, and it won't help in every situation. And the dosages, I'm telling you, you know, it's a body surface area converted to weight, converted to a dosage syringe, and you may have to go 1 dot up or 1 dot down from the recommended range. But most dogs can find something that works for them. There's the occasional dog that just doesn't respond to this. You can make this up, and there are numerous papers looking at using a homemade solution for veterinary exams, sedation for short procedures, sedating aggressive or anxious dogs, and sedating dogs for minor procedures in veterinary exams. And the dosages are 32.6 micrograms with a range of 16 to 40, 20 micrograms. If you look here, we've got a cat dose of 20 micrograms per kilo body weight. So, you know, all of these per kilo dosages are factored on the body surface area conversions. And I see that there are chats, but I'll come back to them in a minute when I sum up. Gabapentin has been used to see if you can lower stress during intradermal testing, and you can in cats. 25 to 35.7 milligrams per kilo in that study. Decreased stress at transport, cats, 100 milligrams per cat, which turned out to be 13 to 29.4 milligrams per kilo, given 90 minutes before transport and examination. Now, these are cats that are trapped as part of a trap, neuter, release program. Sedated, trapped, caged community cats, again, TNR, a slightly higher dosage, lower on this end, higher on this end, but they came in at a mean dose of 35.3 for the high dose group and 16.3 for the low dose group. Okay. For veterinary visits, dogs, 20 plus milligrams per kilo. Many behavior specialists are using 30, 40, 50 milligrams per kilo in exceptional cases. You can start it 2 to 3 days before the visit. You can give it the night before and the morning of the visit, and again 2 to 3 hours before the visit. We often start this a couple of days before, Q8 to 12 hours, and then the morning of they get an additional dose, an hour or 2 before the visit. We usually, since they're already taking it, we usually try to get it in about an hour before the visit based on the published pharmacokinetics. We have many dogs who are taking gabapentin twice a day anyway. And we can give them an extra dose. And when we give them that extra dose, we tend to also boost the dose for the veterinary visit. Trazadone, sedation for veterinary visits. That's actually what the paper said. There's your dosage range to cats, 10 to 33. For sedation and handling for veterinary visits for cats, 7.7 to 15.2 for transport. Confinement, stress, sedation in dogs, 3.5 to 10 milligrams per kilo. For behavioral signs of distress in hospitalized dogs, these are dogs who were in a surgery unit and were distressed, 4 milligrams per kilo Q12 hours to start. They ended up with 8 to 10 milligrams per kilo every 8 hours, and they gave it 90 minutes before the procedure. And for anxiety associated with post-surgical confinement, this is the placebo-controlled double-blind study, and there was no effect. And the dosage range was 2.8 to 10.8 milligrams per kilo every 12 hours. And there was no effect shown when you compared the placebo group to the interventional group. The rest of these studies did not have a placebo group for the most part. Okay, and that's the problem. So I want you to consider that we may not know what we don't know. When you look at alprazolam, it has been used in cats for panic prior to or caused by veterinary examination or transport. Very tiny dosage, 0.0125 to 0.25 milligrams per kilo body weight, 30 to 60 minutes before an appointment, or in an interventional manner if they become distressed. For dogs, there's actually a publication. For cats, there isn't one. And the dosage range was 0.2 to 0.02 to 0.04 milligrams per kilo in an interventional manner, or given 30 to 60 minutes before the appointment. The lovely thing about benzos is even if you can't get the pill into the animal, you can put it into the cheek pouch and it will dissolve. Okay, now let me say something before I go to the chat. How long should you try to do this without using the meds that I just told you? You probably need to use more often than not. And what happens when you make a mistake? One of the things we learned from Camille's study is if you're still trying to do this 10 minutes later, I don't care if it's draw blood, examine the animal, whatever, stop. You've gone over the dog's time limit. Don't go any longer than 10 minutes. And if you make a mistake, interventional medications, alprazolam, it'll help abort short-term memory formation and it'll help calm them down so they won't hate you so much the next time. And here's our rule, and we're going to talk about this more in the second webinar when we talk about why we don't want to use restraint. Here's our rule for the study about taking blood. And we had a 10-minute rule. And we use the saphenous vein. If you got it, you're done. If you didn't get it, saphenous vein on the other leg. If you got it, you're done. If you didn't get it, you move to a cephalic vein. Did you get it? No. If you didn't get it, you're done, period. No more than 3 veins. No more than 1 blown vein, even if the dog moved accidentally. And we're doing this with lidocaine over the veins in all of our patients. And in the study, all the dogs in the interventional group got lidocaine. All the control dogs didn't. The results were clear. And what we can see is that within 10 minutes, if you've gone more than that, you're not going to get it no matter what. All you're going to do is get distressed. But without restraint and without horrible interventions, you can actually get what you want if you do everything that has been developed here. And one of the lovely things that happens is when you have this type of medical protocol, you can put in patients' records when they're special needs dogs. And these are 6 of Camille's special needs dogs, and they were in each group. Some of them were in the interventional group. Some of them were in the control group. And we learned that this dog needed 5 dots of Cilio an hour before the appointment and at least 20 minutes before being put in the car. And he did best if we drew his blood outside. Little Chihuahua, if we burritoed this Chihuahua, the Chihuahua was completely calm. A golden retriever who was older and painful. We shaved this dog so you could see the vein. We took the dog where the light was good, or we used a halogen light so that we could see the vein. He had to be kept cool. He overheated very easily. He had to stand. You could put no pressure on his joints, and you could get the blood. This little dog needed 2 to 3 dots before getting into the car to come to the appointment, or give it to her when she arrives and she sits. This little Shih Tzu mix, 2 to 3 dots. And check on him an hour before the appointment, or she comes and she waits. We burritoed the dog with a back leg sticking out. It took 2 minutes. And one dog, we just needed to let him lean on somebody and stand on somebody and get cuddled and do a back leg, and we didn't have any problems. So these are relatively inexpensive. None of these medications are going to break the bank. The most expensive medication here is Cilio, and you're not going to use that much for these interventions. So relatively inexpensive, targeted interventions are cost and time effective. They save both quality of life and lives. And I just think we've got to change the way we practice. And yes, you should be using pre-veterinary visit pharmacological intervention. If you want to reach me, this is my email address. If you want to email the behavior clinic, and we do distance consults, it's avcbehavioralmed@upei.ca, spelled the British way. If you want to look at clinical forms, including the distance consults, instructions, price lists, here's the website. Here's the journal website. As I said, my website is karenoverall.com. Handle is Dr. Karen Overall. So let me look at the chat. Cilio is, I'm loving it already. Okay, yeah. So let me go through these and the questions, and I'll just do this. Oh, Katie, you're wonderful. Katie put the AHA guidelines up there. Is Cilio available in Canada right now? No, it's not, but it will be. Okay, the launch is expected sometime after November this year, and it should be readily available after the first of the year, I am hoping. Is compounded dexmedetomidine as effective as Cilio? And that was what all of those other studies were. They compounded it or they put it in a solution. Part of the magic of Cilio is it's in a gel that sits on the gum and enhances absorption. Only 4% of it gets into the systemic circulation. The vast majority of it goes through the circulation, the cranial circulation, directly to the locus coeruleus, which is the center of norepinephrinergic, the sympathetic neurons that innervate the brain. That's the magic of Cilio. You can get a very similar effect with an oral solution or a solution made with honey to make it stick, but you don't get the dose control effect. And as soon as you're into an oral solution or a solution where you're not sure how the dosage is coming across, you may be getting more into the bloodstream. Even if the dog swallows Cilio, it's denatured in their stomach. It depends on what happens vascularly, whether the same thing happens with the compound. Has anyone, Jill has asked, whoa, 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 things keep moving around here. Are there concerns about owners getting Cilio in their skin and having it absorbed and causing problems? It's such a low dose, the chances of causing problems are minimal. However, it's recommended that clients wear gloves. We have all of our clients wear gloves. We wear gloves. If you get it on your skin, you can expect local blanching, and you have to wash. If we think people have gotten it on their skin, we have them immediately wash with warm water and loads of soap and rinse very. Has anyone looked at the size of the room, the placement of the chairs, etc.? No, and they should, but I will tell you this, Camille's study controlled for that. So we had chairs in a specific place for the control group, chairs in a specific place for the interventional group. We controlled where the humans were. We looked at those things. The exam room we currently use for our patients is probably, I should actually measure it. It's at least 12 by 8 feet, might be bigger than that. It's got windows on 2 sides. It's got a giant video monitor. It's got sofas. It's got chairs. It's got a little table with 2 chairs where people can put their laptops. What it lacks is an exam table. That's a clue. And the dogs love being able to look out the windows, and we have blinds we can put down. What pre-visit meds would you recommend for a nervous 1-year-old German short-haired pointer with pulmonary hypertension and a tricuspid valve dysplasia and right atrial enlargement? This poor guy, no wonder he's anxious. First of all, this is weird. You say nervous 1-year-old German short-haired pointer with all of this stuff. I would have this dog have a behavioral workup immediately. Why? Because I am not sure that being nervous isn't contributing to some of his cardiac disease, and I'm not sure that his cardiac disease isn't contributing to being nervous. And it may be that if this dog was given gabapentin every day at a sufficient dose, which would not affect any of this, he could do quite well. And that's the lead-in for what you can give him in a clinic situation. You could certainly give him gabapentin. You could certainly give him a benzo. You would lower his blood pressure a little bit with an alpha agonist, and you may wish to find out what that does under cardiac supervision. But if you don't, you can certainly give him a benzo. or gabapentinoid. Put questions in the Q&A box. Thanks, Katie. I'll get to that in a minute. Maybe you need a new resident to look at this. Wink, wink, nudge, nudge. Thanks, Jill. Glad to see you're still doing well and have a great sense of humor. Yes, we're hoping to have a new resident, in fact.
Karen, before you go to the Q&A box, there was a follow-up question from Juanita about gabapentin.
I missed it.
And what it's in the Q&A box. But
oh, it is in the Q&A box? Okay.
The question is, what dose would you start?
Oh, here. What dose would we start? And this is for the German short-haired pointer, right? I would start that dog on 20 milligrams every 12 hours and ensure that the dog is not sedated. And then I would move up probably, unless the dog is like magically much calmer, and some are in a few days. After a week or 10 days, I would probably move up to 30 to 35 milligrams per kilo every 12 hours and see how they do. I would chart this out. One of our veterinary students actually has her dog wear a pet tracker, and she was able to print out the record just using the standard pet tracker, no enhanced software, of the dog's sleep cycle. And for the first time, the dog was sleeping through the night, and she had the printouts for the dog before the gabapentin, the printouts for the dog after the gabapentin, and you could see the decrease in arousal and anxiety. The reason I mentioned that is this dog, especially with its medical history, may in fact need gabapentin or something else more frequently and maybe at a lower dosage. So you may end up with 20 or 25 milligrams 3 times. But in the dog, you may be able to pick up those signs of anxiety. We've had him to a cardiologist in Nova Scotia, and he's on atenolol. Okay, so you are addressing much of this. Would this be a problem? Not with the gabapentin, absolutely not, and it won't be with a benzo. Hannah asks, what about reversal in patients who are using a larger dose of cilia? Yeah, you can reverse this. You can reverse any alpha agonist, but you can certainly reverse this the same way you would injectable dexmedetomidine. I tend not to, mostly because I haven't had a dog sedated by it in a clinical situation. Were the dog sedated, I would probably reverse it. If the dog can still get in the car and go home, they'll sleep it off. And I sort of let them sleep it off so that it's very smooth. Any consideration for benzos and aggression? I hate this question, and I'm very glad you asked it. I hate this question because there is this impression in the literature, and I can hear my resident Camille rolling her eyes and giving the response to the clients, that benzodiazepines disinhibit aggression. They only disinhibit already inhibited aggression. So they will not create aggression de novo. And we have people do a trial and find out if they think there was inhibited aggression and they know it's situational, they may get to see it come out, and they can either make their decision to not use the benzo or to be more cautious during that time. But the vast majority of people who have avoided benzos because they think it disinhibits aggression, period, think that that means it creates it de novo, and it cannot. Okay, and I'll give you my example. I had a little dog that we inherited from my father-in-law, little bit, 9 pounds, 13 teeth, nasty, nasty, nasty little lab rat crossed with Chihuahua and some kind of terrier. I don't know. She became lovely, but was not a nice dog at first. She was worried about storms, and over the years, we had managed to address her aggression. She became absolutely charming, jumped up to get in your arms, licked you, handled a house full of Australian shepherds, absolutely wonderful. She was afraid of storms, so we would give her alprazolam. And one day we had to take them for the car ride while she was taking the alprazolam for the storms. And like usual, she got in the car, and like usual, an Australian shepherd bumped into her, only this time she turned around and attached herself to him. That was disinhibited aggression that she already had. And she had learned not to be nasty to the dogs in the car, except when she was drugged because of the storm. That's entirely different. Is there any study that in some cases Trazadone can create some aggression? I've had some clients mention this. Pretty much all of these drugs can reveal things that you may not have known. At high dosages, Trazadone is extremely disorienting to dogs. And you will find even the nicest dog having trouble holding on to their sanity, and they can get a little snappy, and you wouldn't have thought it. There are paradoxical reactions to everything. And, you know, even with the alpha agonists, you can have a sudden reaction to noises that's atypical. So we need to think about these things when we use these medications. And we've even had some dogs on gabapentin who just, it's rare, but we've seen some dogs who are just not themselves. And maybe it's because maybe they're a little sleepy, I don't know, but they change a little. And the example Jill gave was a dog who's very aggressive, lunging, snapping, 40 milligrams of gabapentin, 7.5 milligrams of Trazadone, and cilia 1 hour and 20 minutes before. Is injectable sedation the next step at another visit? Yeah, it is. And in fact, when I look at that dog who's doing this, unless that Trazadone gives you something that a benzo and gabapentin and the cilia doesn't give you, I would actually take it out of the equation. Because now you're going to have a sedative effect upon a sedative effect, because you're going to give this dog injectable dex that you are going to have to reverse. And you're not going to be able to tell because of the Trazadone sedation. So I would take it out. But yeah, and what we do is we have clients practice. Now, we use clonidine sometimes, and we use high dosages of clonidine in these situations. And I have to tell you that even our very aggressive patients with some combination of gabapentin, clonidine, and cilia, we've been able to even draw blood from during exams. So part of it is trying it out once at that combo, sending the dog home, trying it out again a week later in another combo, sending the dog home, trying another variation, sending the dog home. Which one of those gave you the best opportunity to give him an injection in the car or the parking lot? That may be where you're going. And it's certainly something we think about. One of the reasons that the compounded dexmedetomidine may be a hidden gem for some people is the emergency situation where you've got a dog who has to come into the hospital. They weren't expecting it, and you can't get near the dog in the car. Okay, and this happened a lot during COVID, and we're about to have another wave, so it's going to happen again. In that situation, one of the things Camille and I were recommending is they made up the oral solution, and the client just squirted it into the dog's mouth. Okay, and if you're a little over, a little under, you don't care, it's going to fall asleep. And a little under, you can do it again. But it may be a way to help get them some of the care they need in an emergency situation where you can't premedicate the dog. Once a dog has exhibited the need for premedication, would you continue to premedicate for every visit as precaution, or would you eventually try without? It's a trick question. I would always keep medicating the dog, just like I would always take out every appendix that might be operable. And if I'm not getting 10 to 20% that would have done okay on antibiotics, I missed hot ones. I'm not willing to take the chance, and I think that what you'll find, and it's what the little Shih Tzu mix's owner found, she basically said to us, since I'm in the study, every time he has to come back, whether or not Cilia's here yet, can we use cilia? I mean, she didn't care if he got better. What she cared about was that in the here and now, he didn't suffer, he wasn't upset, he wasn't trembling, he wasn't there very long, he got the care he needed, no one restrained him, and he wasn't unhappy. And she was willing to do that for the rest of this dog's, what I hope will be a very long life. The dog's only a year. So there you are. Hannah asks, what are your thoughts on the CALM protocol, ACE, promazine, gabapentin, and melatonin? What about replacing ACE with Cilio? There are no data, good data for melatonin in dogs, and a lot of dogs have some paradoxical effects. And I would sort of put that in the realm of most supplements. We have no data, and people's claims are in excess of what they should be. I take ACE out of everything. There are uses for ACE, but not here. If the dog has any noise reactivity at all, the ACE makes it worse, but I wouldn't have a problem with substituting using gabapentin and Cilio together. We've used gabapentin, Cilio, and even clonidine, believe it or not, because the dog's been on clonidine twice a day, and then they come in and we give them Cilio. Okay, so, you know, he's got 2 alpha agonists on board. And if the dog becomes sedated, we can reverse them. It hasn't happened yet. But they've got gabapentin. We use Cilio situationally. You can use gabapentin, Cilio, and alprazolam. We do that all the time. You can use Trazadone and clonidine if you have the intent to sedate the dog at relatively high dosages. And then you can use injectable dexmedetomidine. And if the dog can tolerate benzos, you could use Trazadone, clonidine, and alprazolam for a sedated dog. And you may, depending on what you're going to do in the procedure, you may want to give another benzo later for the anamnestic effects. But that can smooth out the dog, allow them to be very, very sleepy. They arrive at the vet's in the car, very, very sleepy, maybe in a muzzle, and you give them injectable dex. Those are problem dogs. Let me tell you something, and this is the thing everybody's missing. With the stuff we're going to talk about in the next webinar and this, if you started every dog and cat out this way, your number of problem dogs in 5 years is going to drop to pretty close to 0. If this was the way we did everything, we would prevent most of the problems. And we're missing that. I just think we need to change the culture.